Greetings, everyone, and welcome to the third event in our inaugural Fall Symposium series, the Veteran and Family Wellbeing Series, a person-centered, evidence-based approach to chronic pain. Bonjour tout le monde et bienvenue au troisième événement de notre série inaugurale de Symposium de l'automne. Série sur le bien-être des vétérans et de leurs familles. Une approche de gestion de la douleur chronique basée sur les données probantes et centrée sur la personne. I am Dr. May Zacharias, Chief Executive Officer and Medical Director for the Chronic Pain Center of Excellence. At the Center of Excellence, our mission is to improve the well-being of our Canadian Armed Forces veterans and their families suffering from chronic pain. Je suis le Dr. Ramesh Zacharias, chef de la direction et directeur médical du Centre d'Excellence sur la douleur chronique. Au Centre d'Excellence, notre mission est d'améliorer le bien-être des vétérans de nos forces armées canadiennes souffrant de douleurs chroniques et de leurs familles. Merci à tous de vous joindre à nous aujourd'hui. Maintenant, je vais laisser la parole à nos modérateurs, le général Michel Maisonneuve et général Eric B. Schoolmaker. Thank you all for joining us today. I will now pass it over to our moderators, General Michel Maisonneuve and General Eric B. Schoolmaker.
Bonjour, chers amis. Voici un message spécial de Alex DeBrincat, joueur de hockey des Blackhawks de Chicago. And now, a special message from Chicago Blackhawks hockey star Alex DeBrincat.
Hi everyone, I'm Alex DeBrincat of the Chicago Blackhawks. I'm honored to be a part of today's event led by the Chronic Pain Center of Excellence, in collaboration with the U.S. Department of Veterans Affairs and the U.S. Department of Defense. As a hockey player and an athlete, we all experience chronic pain to some degree throughout our careers and even once we've hung up the skates. Mental and physical pains can be unbearable to deal with, and that's why I train both my mind and my body to get stronger and better every day. As a proud American, I've been fortunate enough to grow up and live in a country with all the freedoms and opportunities in the world, and it's because of the commitment and service of our veterans that I'm able to play the game I love every day. Thank you for your service.
Good morning and welcome to this very special webinar aimed at sharing our collective experience, our wisdom, and the many questions that remain about how to best care for our Canadian and U.S. service members, veterans, and families with chronic pain. I want to thank Dr. Ramesh Zacharias and his colleagues at the Chronic Pain Center of Excellence at McMaster University for the invitation to be with you today, and for the Wasserman team in producing these series. A shout out to our special guests in the NHL who remind us that professional and other athletes have a major burden of pain through which they must work to achieve optimal function. Their support is very much appreciated. I'm Lieutenant General and Dr. Eric Schoolmaker. I was privileged to serve as the former U.S. Army Surgeon General and the Commanding General of the United States Army's Medical Command. I have a passion and an enduring commitment to help those who are suffering from pain, especially those who have served in uniform in all eras to defend our two nations. I'm privileged to serve as the co-moderator for today's unique international forum, the third, as you've heard from Dr. Zacharias, of this four-part series from the Chronic Pain Center of Excellence. You can best join us by signing up via the information box on our website, by asking questions via the information box that's on the right-hand side of your screen, by viewing us in the full screen mode, and then by using closed captions if you're among our French-speaking audience. Now over to a trusted colleague, Lieutenant General Michel Maisonneuve.
Merci beaucoup, Eric. Mon nom est Michel Maisonneuve et je suis un vétéran de l'armée canadienne dans laquelle j'ai passé 35 ans. Je suis honoré aujourd'hui, avec mon collègue, le lieutenant-général Schoolmaker, de servir comme modérateur de ce webinaire. My name is Michel Maisonneuve, and I'm a veteran of 35 years in the Canadian Army. Many veterans suffer from chronic pain as a result of their military service. For them, it's a constant in their lives. So it's my honor today, alongside my American colleague, Lieutenant General Schoolmaker, to help moderate this third of a series of webinars dedicated to helping veterans who suffer from chronic pain. Today, our webinar will follow a bit of a different format from the previous two. We will have 3 separate presentations, which will be followed by a panel discussion and answers to your questions. Notre webinaire aujourd'hui suivra un format un peu différent des 2 autres. Nous écouterons 3 présentations et suivrons avec une discussion en panel où nous répondrons à vos questions. Je vous demande, si vous ne l'avez pas déjà fait, de vous inscrire dans le panneau à droite et vous pouvez poser vos questions de la même manière. Ensuite, il est plus facile de visionner le webinaire en mode plein écran et pour voir les sous-titres en français, il suffit d'activer le mode Closed Captioning ou sous-titrage codé, l'icône CC au bas de votre écran. Alors, allons-y. Notre première présentation sera effectuée par la Dr Patricia Poulin, qui est psychologue clinicienne et experte en réhabilitation à l'hôpital d'Ottawa. Elle s'intéresse particulièrement au traitement multidisciplinaire pour la douleur chronique. Sa présentation traitera de la méthode de traitement par étapes. Elle expliquera le processus par lequel le vétéran pourra recevoir des soins de plus en plus intensifs liés à sa douleur et aussi la version 2.0 de cette approche par étapes. Dr Poulin, à vous.
Good morning, everybody. It's a pleasure to be here with you today, and I want to thank the leadership of the Chronic Pain Center of Excellence for Canadian Veterans for the invitation to speak with you about Stepped Care 2.0 for chronic pain. I want to start by a territory acknowledgement and just acknowledging that the land I'm standing on and sharing this knowledge from today is the traditional and unceded territory of the Algonquin Nation. And I would like to invite you to do the same and just acknowledge the land that you're standing on, listening to this presentation today, wherever you are throughout the country. The objective of this talk is to first describe 2 major framework that we can categorize stepped care approaches under. Then to describe Stepped Care 2.0, I'll go quite a bit more in depth into the stepped care approach that we use at the Ottawa Hospital. And then to discuss the application of stepped care 2.0 principles to chronic pain recovery through actually a case study. Now, in terms of making it your own, as a veteran, a family member, a clinician, or a health administrator, I think that's really a lifelong journey where we can never stop learning. It takes a lot of self-reflection, monitoring, adjustments, refining, evaluation, and then trying it again. Let's get started. So stepped care for chronic pain. So what does it mean, stepped care? So stepped care, in a nutshell, means using interventions that vary in intensity, time commitment, efforts, and resources needed to meet the needs of people living with chronic pain who are seeking our care. There are really 2 major umbrella or categories of stepped care approaches. There are progressive models where everyone will start with lower intensity interventions and then progress to higher level intensity interventions if they fail to make progress with the lower treatment intensities. There's also matching or stratified models where somebody will have a more comprehensive assessments right from the get-go, and then if they have mild symptoms, they'll be directed to lower intensity treatments. If they have moderate symptoms, to moderate intensity services, and then if they have severe symptoms, to really acute and more higher intensity interventions and treatments. Stepped Care 2.0 is a little bit of a mix of both. It's a flexible, progressive stepped care approach. And at the practice level, it's a systematic and flexible approach or system to address the client's mental health and chronic pain needs, taking into account their goals, their preference, their needs, and their readiness. It's very important to start from a person's goal and readiness, because even if somebody might have very severe symptoms, they might not actually be ready to engage in more intensive treatment. And Stepped Care 2.0 is also anchored into recovery principles, which actually I will speak about briefly in a minute. And it favors solution-focused and strength-based, lower intensity interventions whenever that's possible. That being said, it does not prevent access to higher intensity treatments if that's what's going to meet the person's goal, and if the person is ready to work hard. And the way that we make decisions on stepping up or stepping down treatment is through the use of continuous outcome monitoring, where every now and then at regular interval, we ask the person to complete some self-assessment to help orient the next phase of their treatments. Now, I've talked about Step Care 2.0 at the practice level, but for health administrators at the system level, it's really about coming together with people with lived experience, clinicians, researchers, to transform our health system by developing, delivering, monitoring, and adjusting the programs that we have to better meet the needs of all people who live with chronic pain. So not just the people who can and have the tolerance to complete an 80-hour intensive program, not just people who will respond to interventional management, but really for everybody. So with Step Care 2.0, there are really 9 levels of care. Somebody might just at first benefit from learning more about chronic pain, having some information about the difference between acute and chronic pain and best approaches in their management. Somebody might be actually ready to start taking some online courses at their own rhythm and to see what they can learn really on their own. But somebody might actually be interested in meeting other people that have lived experience of chronic pain and learn from their experience. And there are many peer-led self-management programs across the country that people can access. Someone might instead want to take on participating in some workshops that are delivered by a clinician who's been studying and working in the area of chronic pain for a long time. Somebody may feel like, hey, I'm doing this self-management course online on my own, but I need a little bit of help. I need some troubleshooting. And then you can actually schedule 5-minute, 10-minute, 15-minute coaching session in order to help troubleshoot whatever issue is coming up, maybe with pacing, with energy conservation, with making some, implementing mindfulness strategies, or any questions a person may have. Then if somebody is really struggling with something specific, they're ready to get into it, they might be able to participate in group therapy for specific concerns, and I'll share about some of the groups that we offer at the pain clinic. Or they may be ready to participate into a more intensive interprofessional chronic pain rehab program, and we have a few of those available throughout the country. And finally, in terms of the 2 last steps, if they need one-on-one treatment, then that can be scheduled in. And if they're really struggling with managing day-to-day activity, with keeping straight all of these appointments, assessments, they might actually benefit from a case manager who will help them navigate this and access not only the healthcare system, but also community resources in order to better achieve their goals. And in a nutshell, all of this is really to help people fill this pain management toolkit to really make it personal. And I know that you've already had some sessions on the biopsychosocial approach and whole person care for chronic pain, so I will not get into it, but it's very much connected. So just to give an idea of the offering at our pain clinic, we have workshop on assertive communication, on managing stress and anxiety, on pain and trauma, very relevant for people in the audience, veterans who may have been exposed to or experienced trauma, who may be experiencing post-traumatic stress disorder. We have workshops on financial resources, financial literacy, on mindfulness, how to talk to your family, to your healthcare provider, and we have workshop on how to support somebody who lives with chronic pain. Some of the groups that we offer, for example, we have cognitive behavioral therapy for depression and anxiety. We know that is often co-occurring with chronic pain. We have a mindfulness-based pain management course. We have a cognitive behavioral therapy for insomnia, and our social worker runs a number of different support groups and discussion groups. I mentioned earlier that recovery principles are really central to step care, and I will just share with you 2 models. And in a nutshell, there are so many dimensions of recovery, but it's very important to consider that recovery from a chronic pain perspective is a lifelong journey. There's not just one size fits all, and there are many pathways. It's important to feel like there's hope. And I hope that over the next little few minutes, when I share the case study, that you will also feel that if you're struggling with pain. It addresses trauma, it takes into account the whole person, their relationship, and really leverages the experience of people with lived experience as key member of healthcare teams, actually, and of a person's recovery. I'll invite you just to consult these two documents if you're interested in knowing more about recovery. Now I'm going to dive into a case study. So this is fictitious, but it's very, very realistic. This is very representative of people that we work with at our pain clinic day in, day out. So Richard is a veteran who was injured in a motor vehicle accident while deployed overseas. He's paraplegic with severe chronic neuropathic pain in both of his legs. He was seen in another pain clinic 7 years ago. That clinic was predominantly doing interventional management, and he failed to respond to all treatments, unfortunately. Infusions, injections, spinal cord stimulation, he's still having quite a bit of pain. So at the time that Richard is actually being referred to our clinic, he's on 290 milligram of morphine equivalent daily. But despite the fact that he's struggling with his pain on a daily basis, 8 out of 10 to 12 out of 10 pain, he's really pushing himself to be active, in line to participating to Paralympics. And he is also really pushing himself to be present to his family. But this is not the life he wants for himself or his family. So before before the implementation of Step Care 2.0, if Richard had been referred to our clinic, he would have been seen by a physician first, and he would have been waiting for 2 years actually between the time of his referral to the medical visit. Then he would have been referred to either psychology, occupational therapy, physiotherapy, social work, or to our intensive 80-hour chronic pain management rehab program. And for that, he would have had to wait another 6 months. After we implemented Step Care 2.0, as soon as Richard would have been referred to our pain clinic pre-COVID, he would have actually been invited to participate in an orientation and education session where he would have learned about a lot of resources he could access right away to help manage his pain. Now, post-COVID, our wait is about 3 to 4 months. Then he would have seen his physician, and then he would be referred to our interprofessional team for a group intake where we go more in depth into chronic pain and its management. We go over all of the programming that's available. And the good news about this is that Richard does not wait between his medical visit. If he's referred to our interprofessional team today, he's scheduled into that session next week. And then he gets to meet one-on-one with a member of our team and to make a personalized treatment plan. And again, for that, there's no wait. Next week, he meets, he goes into his group intake. The following week, one-on-one personalized treatment plan. And this is what we learned from Richard. So his goal is to reduce his reliance on medication, improve his sleep, sleeping 3 to 4 hours a night, very broken up sleep, and reduce the number of days off due to pain crises. In his meeting with a therapist, he tells more of his story. He's really caught into a push-crash cycle. When he's doing a bit better, he just push to do as much as possible, and then he crashes for 3 days. A lot of self-loading went down. He's not coping well, sometimes using his medication and alcohol. Anxiety is present. He has a previous diagnosis of PTSD, but he doesn't feel it's much of an issue. He responded well to treatment, and the service dog was super helpful. So this is what his treatment looks like at our clinic. Might look like at our clinic. So first, he's invited for participating in a sleep workshop and a pacing workshop. Let's get some strategies right under his belt. And then he participates into our 4-week distress tolerance and emotion regulation skills group. Once he's got this foundation, he comes into our 20-hour chronic pain rehab program. He declined the intensive. It was not quite the right fit for him. In phase 3, sleep is still an issue. He's improved in terms of his ability to pace, his ability to manage pain. His actually reliance on medication, PRNs, has reduced, but he wants to get into his sleep issue. He participates in our 4-week behavioral therapy for insomnia. And there, during that treatment, he learns about mindfulness a bit more and wants to participate in our 8-week mindfulness pain management. So he's, can go into it right after he finishes the CBT program. Afterwards, Richard is actually feeling quite a bit better. He's had his appointment with his physician, with the members of our team, and we're looking at how do we maintain those gains. In phase 5, he basically decides that he's going to enroll in our drop-in online mindfulness session. He's invited to do that, to drop in anytime he wants on a weekly basis. So our goal with this approach is really to eliminate wait time, to make everybody feel welcome. There is something for everyone in our clinic. And because we use group intensively, people really have a sense that they're not alone. Our treatments are adaptable, flexible, they give people choice, and they really target the whole person. Our goal is really to make people feel really empowered and feel like they have the tool to continue to manage and live their lives well with chronic pain. On that note, I'll thank you again for being here today, participating, for your service, if you're a vet in the audience, and just want to acknowledge the team in the Ottawa Hospital and the Ontario Ministry of Health for their funding and support and contribution. Thank you.
Alors, merci beaucoup, Patricia, pour cette excellente présentation et votre cas qui illustre bien l'expérience de nos vétérans. L'une des leçons qui est ressortie de tous nos webinaires est l'importance d'une approche multidisciplinaire qui est axée individuellement envers le vétéran. La méthode par étapes est une excellente façon de mettre cette approche en place. Comme expliqué par la Dr Poulin, le modèle 2.0 ajoute encore plus d'outils et d'étapes pour le traitement. Notre prochaine présentation donnera d'autres détails sur cet aspect avec le témoignage d'un vétéran. A multidisciplinary approach to treating chronic pain is very important, and the stepped care approach is a good way to implement this care. As presented by Dr. Poulin, Stepped Care 2.0 adds more steps and tools for the treatment of pain. And the next presentation will provide more details on this aspect. Notre deuxième présentation sera offerte par Madame Regina Visca. Ms. Visca is the Administrative Director of the McGill Ruiz Center of Expertise in Chronic Pain. En tant qu'employée civile de la Défense nationale du Canada, Madame Visca a travaillé sur le projet des frégates de patrouille pour la Marine royale canadienne, où elle a appris l'importance du travail en équipe vouée à une mission, ce qu'elle applique aujourd'hui au traitement et la réhabilitation de nos vétérans. Madame Visca dirige actuellement le Centre d'expertise sur la douleur chronique de l'Université McGill à Montréal. Elle sera accompagnée par un vétéran de la Marine, Derek Spears, blessé durant l'incendie du sous-marin NCSM Chicoutimi. Derek nous témoignera de ses expériences avec la douleur chronique et le traitement par étapes. Ms. Visca and Derek Spears, a Royal Canadian Navy veteran, will provide more details and personal experiences in the use of step care for the treatment of pain. Regina, over to you.
So hello, everyone. Today, Derek and I will be presenting the stepped care model for pain management. The objectives of our presentation are to present an overview of the stepped care model for pain management, describe the stepped care and how it has been operationalized in the McGill University Integrated Health and Social Services Network, and share the journey and perspective of a veteran. The McGill University Integrated Health and Social Services Network covers a large geographical area and serves veterans living with chronic pain who live anywhere in the province of Quebec. We have based our approach to stepped care on the recommendations of the U.S. Pain Management Best Practices Interagency Task Force, which includes the U.S. Department of Defense and the U.S. Department of Veterans Affairs, as well as the Canadian Pain Task Force, which includes the Chronic Pain Center of Excellence for Canadian Veterans. Both the Canadian and U.S. Pain Task Force recommend a biopsychosocial approach to pain care that is grounded in scientific evidence, is multimodal and interdisciplinary, while tailored to an individual's needs, preferences, beliefs, and values. Now, Derek, can you please tell us a little bit about your unique experience living with chronic pain? How did it start and how did it affect your life?
Well, thanks, Regina. Thanks, everyone, for having me. As a cook in the military, I served for 22 years in the Navy and suffered a few injuries, but I was also a submariner, and in 2004 brought a submarine back from England that caught fire. As a result, I suffered a PTSD-induced seizure in 2006 and fractured 5 vertebrae. And that was the beginning of my chronic pain story. I've had multiple back surgeries since then, and live with chronic pain daily, but I'm still here. So thank you very much.
So to address this multidimensional pain experience, the stepped care model for pain management proposes an individualized approach to managing pain comprising of 3 major steps, with each step integrating comprehensive pain assessments and evidence-based interdisciplinary care plans that are consistent with the individual's goals, needs, and preferences. The first step emphasizes the role of the primary care clinician in identifying and discussing pain concerns and developing a treatment plan focusing on education and self-management. Both people living with pain and their families have access to education regarding the basics of pain management, such as medication adverse effects, the importance of sleep, adequate nutrition, and physical activity. Self-management approaches offer individual strategies focused on altering cognitive or behavioral factors. Physical therapists or kinesiologists are available to support exercising with chronic pain, while psychologists and nurses provide support in coping with sleep, mood, and function, and pharmacists optimize medication. In our network, we have interdisciplinary low back pain clinics, and we'll be implementing multidisciplinary musculoskeletal clinics that integrate the principles of stepped care. Primary care physicians in our network can use electronic consultation to obtain specialist advice to a variety of questions, avoiding unnecessary referrals and ensuring timely access to care. To address some of these factors that predict poor outcomes as early as possible, we are now offering Empowered Relief, a single session treatment for pain catastrophizing based on neuroscience principles developed by Dr. Beth Darnell, a psychologist from Stanford. More specifically, pain catastrophizing, which has been shown to maintain chronic pain, undermine medical treatment, and lead to poor health outcomes, needs to be treated as early as possible. In a randomized controlled trial, Dr. Darnell showed that Empowered Relief was non-inferior to 8 weeks of cognitive behavioral therapy and superior to a health education class for reducing pain catastrophizing and improving multiple secondary outcomes such as pain intensity, pain interference, and receptivity to additional treatments. To achieve these positive outcomes, we are now offering Empowered Relief to people living with chronic pain and their families as they enter the chronic pain programs or are waiting to be admitted. So Derek, can you please tell us a little bit about how you got to St. Anne?
In my situation, after I retired from the military in 2011, I was in Halifax, and I took my last move and came back home to Sherbrooke. I worked a couple years with no knowledge of veterans organizations or anything like that, and was quietly suffering in silence. And one day I met a veteran organization, and they had a few members who were clients at St. Anne's, and I went through my case manager and ended up being seen. It wasn't, in my case, it wasn't too long, a few years ago. I ended up seeing the pain clinic as well as the mental health clinic.
So if there's poor response to treatment or symptoms persist and the complexity of the pain condition increases, then we move to step 2 of our stepped care model, which involves comprehensive assessments and collaborative treatment with multidisciplinary pain medicine teams. In step 2 of our network, the Operational Stress Injury and Pain Management Clinic in St. Anne de Bellevue, which Derek just spoke about, only serves veterans and offers a comprehensive interdisciplinary evaluation to establish a care plan, which involves working individually and or in groups with a variety of professionals such as nurses, physiotherapists, occupational therapists, and social workers, physical rehab therapists, psychologists, physiatrists, and addiction counselors. For instance, St. Anne uses psychoeducation and psychotherapy to work on challenges such as coping with emotions, stress management, adherence to treatment, and commitment to pain management, sleep management, nutrition, substance management, and detox. When professionals in primary or secondary care are unable to satisfactorily manage chronic pain, or there is concern with substance abuse and other severe comorbidities, they refer people requiring significantly advanced diagnostics and interventions and specialized chronic pain services to the tertiary sector of care as part of Step 3. In Step 3, we have an interdisciplinary pain management clinic consisting of pain specialty physicians, neurosurgeons, anesthetists, rheumatologists, physiatrists, interventional radiologists, psychiatry, nurses, physiotherapists, and a variety of other professionals that offer a variety of advanced multimodal treatments such as image-guided and minimally invasive procedures, nerve blocks, trigger points, individual physical therapies, and behavioral health approaches for severe mood and anxiety disorders, traumatic psychological injuries, and substance abuse. We also have a 9 to 12 week intensive interdisciplinary chronic pain rehabilitation and self-management program. It is important to note that a stepped care model of pain management encourages a multidisciplinary approach using one or more of 5 treatment modalities across the 3 steps or levels, mainly medication, restorative and physical therapies, interventional approaches, behavioral approaches, and complementary and integrative health. Examples of each are listed here. Within each of the 5 broad categories, treatments vary in complexity and intensity, and some treatments will only be offered at Step 2 or 3. For instance, neuromodulation will only be offered at Step 3. All of the modalities integrate education and self-management tools and can be delivered in person or virtually and supported by peer groups and various apps. The choice of modality really depends on the pain diagnoses, the mechanisms of pain, and related comorbidities identified following a thorough history, physical exam, other relevant diagnostic procedures, and a risk-benefit assessment, and most importantly, the preferences, needs, and beliefs of those living with chronic pain. Derek, would you like to describe your journey at St. Anne's to illustrate the specific characteristics of the program and how the program has helped you?
Well, for my journey, it's been absolutely fantastic. They have given me the tools to help me manage my pain and accept the fact that I'm a different person now. I'm not the soldier I used to be. And that we do have a life after the military, and there is ways to manage and control our pain. And it's a slow process. It's one day at a time, but it's possible. I'm here to tell you. Very happy.
Thank you. So finally, while we have seen positive outcomes in our programs, we can still improve the timeliness of access and the quality of care offered. In order to ensure that people with pain are seen at the right level in a timely manner, we are integrating tools to the STEPPed model to identify risk factors that will facilitate access to specialized care more rapidly. Risk stratified care assumes that individuals with poor outcomes can be identified at an early point in their care pathway and the risk of poor outcomes reduced by early targeted interventions. We are currently working on future models of care that will use big data sources and artificial intelligence methods to identify risk factors to help people receive individualized and humane care at the right time, at the right place, resulting in better health outcomes. Derek, do you have any final words?
My final words is reach out, don't stay home alone. There is help out there. There's organizations, and you're not alone. Thank you very much.
Thank you, Derek. It is an honor to work with you and the Chronic Pain Center of Excellence for Canadian Veterans to improve the well-being of veterans and their families. Thank you.
Thank you very much, Regina and Derek. On top of all the efforts we're making in finding improved ways of treating chronic pain in our veterans, you've truly shown that there is hope. Now I'll turn it over to Dr. Schoolmaker to introduce the next presenter. Eric?
Thank you, Michelle. It's my privilege to introduce a clinical leader in chronic pain management in the United States Department of Defense, Dr. Diane Flynn. A board-certified family practitioner and addiction medicine specialist. She's a former U.S. Army physician with deployment experience in both Kuwait and Afghanistan. She served as the chair of the Department of Family Medicine and subsequently the chair of the Department of Pain Management at one of our larger medical centers, Madigan Army Medical Center in Fort Lewis, Washington, in Tacoma. She's been a pivotal leader in the U.S. Department of Defense in advancing workable operational solutions for chronic pain management by building patient-centered, multidisciplinary teams to tailor care for the needs of the individual. Thank you for being with us today, Dr. Flynn.
Thank you, General Schoolmaker. It's a pleasure to be here today. At the end of today's presentation, participants will be able to explain the concept of the step care model of pain management, list 3 self-management approaches that are effective for chronic pain management, and list at least 3 types of pain therapies that do not involve medications, injections, or surgeries. The step care model of pain management was spearheaded by the United States Veterans Health Administration and in 2010 was endorsed by the DoD VA Pain Management Task Force, which was convened by General Schoolmaker when he was the Army Surgeon General. In 2018, the Defense Health Agency reaffirmed the step care model of pain management for the military health system. The step care model is summarized on this graphic. You can think of this model as layers of an onion. The outermost layer is self-management, shown in beige, and it's the foundation of pain management. Self-management pertains to effective approaches that people living with pain can do on their own on a regular basis to manage pain. And in a moment, I'll discuss some of these approaches. Simply stated, the model asserts that for pain conditions that are more complex, more specialized care is recommended. When self-management approaches are insufficient, the next step is seeking care from a primary care clinician in the patient-centered medical home. In the presence of certain factors such as severe pain, mood disorders, need for referrals to other clinicians, use of the emergency room, certain sleep conditions, opioid use, poor response to primary care management, functional limitations, or other medication concerns, the primary care clinician will involve other members of the primary care team, referred to as the medical neighborhood. This may include a behavioral health provider, clinical pharmacist, physical therapist, care coordinator, or consultation with the pain specialty team through telementoring. If response to treatment is insufficient, or if there's a concern for substance use disorder, the individual may be referred to a pain specialty clinic. Several medical centers in the U.S. military health system have established interdisciplinary pain management centers staffed by pain specialty physicians, a nurse case manager, clinical pharmacist, health psychologist, addiction specialist, physical therapist, and acupuncturist. Some also include an occupational therapist, chiropractor, yoga therapist, and massage therapist. When pain intensity is better controlled, mood is improved, referrals are completed, medication risk is reduced, and function is improved, the individual returns to primary care and self-management. Another way to view the stepped care model is shown in this graphic, and I'll go through each component of the graphic. But the important point I want to make is that for most people living with pain, there's not one single treatment approach that provides optimal response. Typically, a combination of treatment approaches works best. Some of the approaches listed on this graphic are effective for some people, but we don't know which will be most effective for any given individual. Therefore, I encourage those with pain to have an open mind and try as many as possible to determine the most effective combination of therapies. Self-management approaches that can be effective include establishing treatment goals that are aligned with each person's values, Education about pain can help. For example, this graphic is directed at education about pain. Physical movement is a critical component of pain management. Exercise is among the most consistently beneficial approaches to chronic pain. And no single type of exercise has been proven to be superior to another. So it's recommended to select a type of exercise that any given person is motivated to engage in. Behavioral health approaches that can be effective include cognitive behavioral therapy, mindfulness, meditation, progressive muscle relaxation, and biofeedback. Physical therapy and occupational therapy are often effective and can help those with pain to develop a home exercise program. Complementary and integrative therapies such as chiropractic or osteopathic manipulation, acupuncture, yoga, and massage can be effective. Interdisciplinary programs that combine self-management, behavioral health approaches, and physical or occupational therapy can be a good option when less intensive approaches have not provided sufficient relief. Medications such as non-steroidal anti-inflammatory medications, acetaminophen, and prescription medications may be effective. And choice of medication is based on the specific pain condition and other common conditions that may be present. This table shows medications that are recommended and not recommended for common chronic pain conditions. The yellow portion of the table shows the most common pain conditions we see in our interdisciplinary pain management center: acute low back pain, chronic low back pain, neuropathic or nerve pain, osteoarthritis of the hip and knee, and fibromyalgia. The right side of the table shows common conditions that may not have brought people to our clinic, but they may have in addition to the problem they were referred for, such as insomnia, headache, both migraine and tension type headache, depression, anxiety, and PTSD. The left side of the table lists medications commonly used, both topical medications that are placed on the skin and oral medications that are taken in pill or capsule form. The green circles and check marks are medications proven to be effective for selected conditions, and the red circles and check marks are those proven not to be effective or the harms outweigh any benefit. For example, the most common condition we see in our clinic is chronic low back pain. There are no topical medications that have been proven to be effective for low back pain. Oral medications that are effective for some people with chronic low back pain are non-steroidal anti-inflammatory medications like ibuprofen or naproxen. Acetaminophen, on the other hand, has been proven not to be effective for low back pain, so we don't recommend it. Duloxetine is a prescription medication that's taken once daily that can reduce low back pain. Tramadol, which is a weak opioid, may also help, but we rarely use it in active duty service members because it can interfere with military deployments. Muscle relaxants may help for acute low back pain, but are not effective for chronic low back pain. Oral steroids like prednisone are not effective. Benzodiazepines like Valium are also not effective and have significant risk. Opioids are not more effective than safer medications and have significant risks, so are not recommended. For another example, consider the person who has chronic low back pain as well as arthritis of the hip or knee and depression. The table can be used to identify a medication with potential benefit for all three conditions. You can see that duloxetine is effective for several common conditions. The other therapies that can provide relief for some chronic pain conditions include therapeutic injections and, in some cases, surgery. Again, for most people living with pain, a combination of these therapies is the best approach. The key takeaways of this presentation are: the step care model was adopted by the U.S. military health system. Self-management is the foundation. And the more complex the pain condition, the greater the intensity of care. And for most individuals living with pain, a multimodal approach is recommended. Thank you.
Thank you for a very clear and informative presentation, Diane, and to all of our presenters. I'd now like to ask all of our speakers to rejoin Lieutenant General Massonov and me for a live question and answer period. The format is going to be that I'll pose a question in English, and after an answer in English, Lieutenant General Massonov will represent the question in French for our French-speaking audience, to then be answered in French. So Dr. Flynn, we're going to start with you. Our first issue is one that you emphasized in your talk, and that is that each of our Canadian veteran guests, including Garrick today, has emphasized the importance of the patient's ownership of his or her own pain, as well as to gain the tools and the skills to ameliorate it, to figuratively look at their pain in the eye and take possession of it. Can you comment on your perspective of this notion and your experience and practice around it?
Yes, thank you, Lieutenant General Schoolmaker. You know, I think a lot of times when people living with pain go to physicians or their healthcare providers, they're looking for a cure. They're hoping that their condition can be fixed. And healthcare providers like to be fixers. We like when someone comes to us with where we can offer a fix. They come to us with strep throat and we can offer a cure with an antibiotic, or a surgeon likes to be able to offer a cure to someone who comes with an inflamed appendix by doing, removing the appendix and fixing the problem. But unfortunately, with most chronic conditions like diabetes or asthma, the management of chronic pain is typically not resolved with one simple fix. It requires a combination of therapies, and it requires time and effort on the part of the person who's living with pain. Management of chronic pain requires change in behavior, a change in lifestyle. It requires, exercising, even on those bad pain days. It requires making time for mindfulness or yoga or whatever it is that's been shown to be helpful for an individual, even on the busy days. Several years ago, I attended a class for US veterans that was being led by Tony Mariano, a pain psychologist from the university, from the Seattle VA hospital. And he was talking about how his team was there to support the veterans more in the role of a coach than as a fixer. And the way Tony phrased it was, we will meet you 49% of the way. And by that, he meant the majority of the time and effort of pain management really fell to the veterans. Thank you.
Alors, je vais répéter la question en français pour Patricia, Regina et Derek. Tous les vétérans qui ont participé à nos webinaires ont réitéré l'importance pour le vétéran ou la vétéran de s'approprier leur propre douleur, de lui faire pleinement face. Pouvez-vous commenter cet aspect du traitement dans votre expérience et votre pratique? Premièrement, on va commencer par le Dr Poulin, puis Regina et enfin Derek.
Oui, absolument. En effet, la relation que l'on entretient avec la douleur va avoir un effet sur cette douleur-là, sur la façon dont elle la gère, sur les émotions qu'on vit en relation avec elle, sur les pensées qu'on a aussi en relation avec elle. Et tout ça va avoir aussi un effet sur notre douleur et notre qualité de vie. Comme Diane a mentionné, l'idée que la gestion de la douleur chronique, pour quelqu'un qui vient dans notre clinique, on va les rencontrer à 49% du chemin, et ça veut dire que 51% du chemin vient de la personne qui souffre avec la douleur chronique. Donc, la douleur chronique demande beaucoup d'une personne. On doit s'engager à faire des différentes activités pour la gérer. Des fois, il faut se retenir d'en faire trop et vraiment être capable de modérer nos activités. Des fois, il faut aussi être capable de s'engager dans des exercices, dans l'auto-soin, même les jours où est-ce que ça ne nous tente pas, où est-ce que ça va très mal et peut-être où est-ce qu'on est dans une crise de douleur assez aiguë. Donc, les professionnels de la santé, on aime vraiment guérir. On aimerait bien avoir la baguette magique qui pourrait nous permettre de guérir la douleur chronique, mais malgré les recherches qui s'accélèrent au niveau du traitement de la douleur chronique, on n'en est pas là. Donc, on doit vraiment s'en tenir à beaucoup d'autogestion et d'investissement de la part des vétérans qui souffrent de douleur et pour atteindre la meilleure qualité de vie possible. Merci.
C'est Regina.
Oui, donc je suis tout à fait d'accord avec Dr. Poulin et Dr. Flynn et j'aimerais juste rajouter donc qu'est-ce qui est important, c'est que dans tous les paliers de soins qu'on a vus dans le modèle par étapes, que les professionnels de la santé intègrent cet aspect d'autogestion dans chaque rencontre avec les vétérans ou les personnes souffrant de douleurs chroniques. Donc, l'idée, c'est vraiment d'avoir une prise de décision partagée et un certain ownership du vétéran et également d'établir des objectifs soit liés à la pharmacothérapie ou à la thérapie cognitive ou à l'exercice et d'établir une fréquence avec laquelle on peut faire des suivis ou des rappels avec les vétérans quelques fois par semaine pour s'assurer que tout va bien. Et notre rôle devient plutôt un rôle de coach pour les soutenir dans la mise en place de ces plans d'action avec des objectifs qu'ils auront déterminés. Donc,
Eric, peux-tu rajouter quelque chose?
Oui, bonjour. Ça, c'est une bonne question. Puis, de mon côté, je vais vous donner un petit exemple. Moi, je suis un ex-cuisinier. J'aime ça faire des sushis. Puis maintenant, avec toutes mes douleurs chroniques, je ne suis pas capable de faire mes sushis de A à Z comme je faisais avant quand j'étais militaire. Si je le faisais, bien là, je souffrais pendant des jours après. Mais à la clinique de la douleur à Sainte-Anne, qu'est-ce qu'ils m'ont appris? C'est que je suis capable d'étirer la façon que je fais mes sushis. Fait, le matin, je vais faire cuire mon riz. Je prends un break. Je vais couper mes légumes. Je prends un break. Une fois que c'est tout cuit, là, je commence à rouler. Je prends un break. Je mets ça dans le frigidaire. Là, quand la visite arrive, je commence à sortir mes choses tranquillement. Je commence à préparer mes choses tranquillement. Je n'ai pas le choix. Tout ce que je fais aujourd'hui, il faut que j'y pense. Sinon, je vais souffrir. Puis Sainte-Anne, ils m'ont donné les outils pour le faire. Puis nous, les ex-militaires, on est très têtus. T'sais, ils vont nous donner un exercice ou de quoi à faire, bien, on a tendance à en faire trop, puis après ça, on souffre. Fait que c'est important de le faire, de le mettre en étapes, puis tout faire ça d'une séquence. Puis la douleur chronique, elle va toujours être là. C'est mon petit jumeau qui est à côté de moi, qui me parle, puis il s'agit de trouver des façons de le gérer.
Merci, Eric. Merci, Derek. Merci. Eric, back to you.
Dr. Flynn, thank you, Michelle. Dr. Flynn, the step care model of comprehensive pain care being adopted both by the U.S. Department of Veterans Affairs and the Department of Defense, and highlighted today by both of our Canadian colleagues and by Derek, who's received services through it, rests first on self-care, as we've talked about, and then on primary care. Of course, we all agree, I think, and we'll emphasize that we want to deliver care at the appropriate level, at the appropriate time. Access to primary care providers who are trained and competent and confident about managing pain at their level appears to be a key element, though. And it's not simply referring patients to the highest specialized level of pain clinic without assessing and attempting management, if appropriate. Could you please address the need for good access to primary care and to overcoming the obstacles that are presented by the remoteness of many of our US and certainly our Canadian patients? And then how do we use information technology enablers such as the ECHO program or telehealth to assist in that?
Yes, thank you, Lieutenant General Schoonmaker. Yes, primary care providers are well suited to provide comprehensive pain management. They often are the providers who know their patients best. They know their patients' families best. They know their community resources and when the resources are challenged. They're well trained to identify and treat some of the conditions that Dr. Poulin mentioned that often occur with pain, such as insomnia and depression, and PTSD. There are certainly times when the primary care provider will appropriately want to get other health professionals involved in a patient's pain management plan, such as physical therapists or psychologists or interventional physicians. But the primary care provider is often in a good position to coordinate this care best. Now, it is critical that primary care providers have the skills and support to care for people with pain. And in the US, VA, and DoD systems, you mentioned we have a telementoring program called ECHO, which is short for Extension for Community Healthcare Outcomes. And this is a weekly telementoring VTC where pain specialty teams at military centers reach out to primary care teams in their region. So in our region, for example, we're based in the Tacoma, Washington area. We co-facilitate our weekly ECHO with the Seattle VA. And our outreach goes to Bassett, all the way in Fairbanks in Alaska, and throughout Washington State. And in each of these sessions, it's a 90-minute virtual session. The first part of each session is dedicated to a didactic, so an educational topic on a pain-related topic. And after the didactic session of the ECHO, we proceed to case-based teachings. And this is where primary care providers throughout our region will discuss their patients to our interdisciplinary teams. So no names are used, so we're protecting the identity of the veteran, but the primary care provider will tell us the veteran or the soldier's or the family member's story and ask specific questions about how to manage this patient's pain. And the beauty of this approach is not only does that provider learn how to manage that patient, but all of the providers who are listening in are learning things that they can apply to patients who they see. Now, I'm a family physician, and most of my career was spent in primary care. So when I transitioned about 10 years ago to pain management, much of what I learned was through ECHO. So I'm a true believer in this approach. Thank you.
Merci beaucoup. En fait, si je pose la même question en français rapidement, parce qu'on a juste quelques minutes, en gros, c'est l'utilisation des moyens technologiques pour aider le traitement de la douleur. Et on va commencer premièrement par Regina, ensuite Patricia en quelques mots et Derek, si vous avez quelque chose à rajouter. Regina?
Oui, donc rapidement, c'est que souvent en première ligne, les médecins de famille n'ont pas accès aux ressources requises pour la gestion interdisciplinaire de la douleur chronique. Alors, on met en place un programme, en fait, il y a deux modalités. Une, c'est la consultation numérique. Donc, les médecins de famille peuvent rapidement poser une question à un spécialiste pour confirmer soit un diagnostic ou un plan de traitement. Et ceci permet à la personne vivant avec la douleur chronique de rester avec son médecin de famille pour la suite des traitements. Et il y a également le programme ECHO, donc qui est une discussion de cas qui se fait sur un patient qui n'est pas identifié. Et donc, c'est la première ligne qui présente le cas à une équipe interdisciplinaire de troisième ligne. Et la première partie est 10 minutes de session éducative et la suite est la discussion de cas. Donc, tous les professionnels autour de la table essayent d'identifier les problématiques et le meilleur plan de traitement pour ce patient. Et par la suite, il y a un suivi qui est fait avec le médecin de famille. Donc, encore là, le patient pourra rester, n'a pas à voyager plusieurs kilomètres ou centaines de kilomètres pour obtenir un plan de traitement interdisciplinaire.
Merci beaucoup, Regina. Patricia, voulez-vous rajouter quelque chose?
Oui, je voudrais mentionner aussi que présentement, il y a un consortium de partenaires qui sont en train de se mobiliser pour développer un portail national sur la gestion de la douleur chronique qui va ressembler à l'espace mieux-être qui a été subventionné par Santé Canada, qui offre des services à tous les gens qui ont des problèmes ou des challenges ou des défis au niveau de la santé mentale ou la consommation de substances au Canada, 24 heures sur 24, utilisant une approche par palier. Donc, pour aussi augmenter la capacité à servir des vétérans et tous les Canadiens qui vivent avec la douleur chronique. Je pense.
Merci. Merci, Patricia. Derek, un 10 secondes.
Ben, moi, je suis capable. Vous êtes capable. Vous n'êtes pas tout seul. C'est aller chercher de l'aide.
Merci beaucoup. Eric, back to you for closing comments.
Thank you. That's all the time we really have for our session today. I want to thank all the panel for their informative and encouraging comments. I want to thank Derek for joining us. Certainly the Chronic Pain Center of Excellence under Dr. Zacharias and our NHL colleagues. We'll conclude our series of weekly webinars next week. And with that, I'll pass it off to Lieutenant General Massaneuf.
Thanks very much. Ceci conclut notre troisième dans la série de 4 webinaires. Merci à tous pour votre présence et vos questions. Merci au Centre d'excellence sur la douleur chronique d'organiser ces webinaires. Nous espérons qu'ils vous apportent de l'aide et de l'espoir dans le traitement de la douleur chronique. Et vous comprenez maintenant que nous privilégions une approche multidisciplinaire dans le traitement de la douleur et une approche basée sur le dialogue entre le clinicien et le vétéran lui ou elle-même. We hope this shared dialogue between the clinician and the veteran will provide what's perhaps the most important thing, hope. I also want to highlight the excellent collaboration with our U.S. colleagues. It's a privilege and an honor to collaborate on this project in order to help veterans from both countries. Je vous invite à consulter notre site web et à nous adresser tout autre commentaire. Je vous rappelle que notre prochain et dernier webinaire est dans exactement une semaine. Thank you for your presence at this third webinar and for your thoughtful questions. And remember, our fourth and last webinar will be 1 week from now. In the meantime, I invite you to go to the Center of Excellence for Chronic Pain website and send us any comments or questions you might have. À la prochaine.